Thanks, Evan, for the whoops. Thanks, Evan, for the introduction. Um, the topic today may be a little bit different from what you normally hear about in a critical care grand rounds, but I still believe it's going to be highly relevant for your practice. And I would guess that more than a small minority of the patients admitted to your ICUs have either opioid or other substance use related disorder. And by the end of the talk, I'm hoping that you'll have a little bit of a better idea on how to manage some of these patients, or at least to manage patients with opioid use disorder. So we're going to talk about opioid use disorder treatment initiation for the non-addiction medicine trained provider. Just some disclosures. I am on the advisory board for Indivior. I will be talking about some of the products that they make. And then I have funding from NIDA, NIMH, and CDC. So these are the three objectives for today. Describe the epidemiology of the opioid epidemic in the United States. And I actually am going to spend a little bit of time on this just because it helps kind of lay out the importance of this topic and why we're talking about treatment initiation in the hospitalized setting and not necessarily in the outpatient setting. And then I'm going to spend a lot of time actually talking about how we do this. So what are the treatments available for initiation and how are they actually used in the hospitalized setting? And then very briefly at the end, I'm going to talk about what you do if somebody has what we call a precipitated withdrawal event during their treatment initiation process with buprenorphine, which is one of the drugs that I'll talk about. So I'm going to start with just some really basic epidemiology and then move pretty quickly into some more complex data. So, unless you've been living under a rock for the last 20 years, you know that the United States has been and continues to be really in a progressively devastating opioid epidemic. Today, opioid overdose is the leading cause of death in adults ages 25 to 54. It outpaces car accidents, injuries from gun violence. It is the largest or the biggest common health crisis the largest public health crisis of our current time. When we specifically talk about the opioid overdose epidemic, we tend to try and break things down into different waves. And this sort of helps us frame kind of moving from one part of the epidemic to another. So it's a continuous pathway, but they do have some discrete phases. So really the first phase started in the late 90s with opioid overdose deaths, most commonly from prescription opioids. And this really corresponds to the overprescribing of opioids by clinicians. And that's really the first wave when we begin to see a rise in opioid overdose related deaths. Starting around 2010, we have a pretty significant crackdown in the amount of overprescribing of opioids. And then as prescribed opioids become less available, there's more of a movement to street opioids, predominantly heroin. And that really makes up the second phase of the opioid overdose epidemic, which begins around 2010. And then you've got the third wave, which we may be in now. We may be in what's called a fourth wave. But the third wave is really corresponds to the rise in the presence of synthetic opioids in the drug supply. So these are things like mostly fentanyl. And fentanyl is been responsible for this really precipitous rise in opioid overdose deaths that we started seeing in 2013 and really kind of took off in 2016. The fourth wave, which is not shown here that some people talk about, is an increase in stimulant-related overdose deaths in addition to opioid-related overdose deaths. And that's really starting around 2016 to 2018. The thing that you'll notice about this slide is that, as you see this big precipitous increase in synthetic opioid-related deaths, you actually do see decreases in opioid deaths related to prescription opioids and heroin. So there has been some progress, at least on those fronts. In terms of heroin, the issue here is that fentanyl has really completely disrupted and displaced the traditional heroin market. So in most parts of the United States, it's actually very difficult to find heroin. In New York, it's almost all fentanyl, and it's very, very rare that we actually will see a patient that has opioids in their urine, heroin in their urine without fentanyl. Most often it's just fentanyl in the urine. So that's sort of the epidemic as a whole. If we break it down into a little bit of a smaller piece and look at the data in a little bit more granular detail, we see something similar, but I wanted to point out just a couple of things. So this is data from the Center for National Vital Statistics. It's 12 months of 12 months of overdose related deaths ending December 2022. And during this time period, there was about 85,000 total overdoses. About 74,000 of those were related to fentanyl. All right, so again, this trend of seeing synthetic opioids as the major driver of opioid overdose deaths. But the thing that I wanted to point out here is in the blue and purple lines, it's this steady increase in stimulant-involved overdose deaths. And this goes to October 2022. I can tell you that the preliminary data, the provisional data for 2023 is not much different. It shows steady inclines in stimulant-related deaths and this continued rise in synthetic opioid-related overdose deaths. Now, it's a little bit hard to put all that in perspective. I mean, it's, you know, how does that equate with what we see on an everyday basis? So this is data from CDC from 2021, basically saying that about 220 Americans are dying every day from an opioid overdose. So it's a really large number. I actually went back because I've been giving this lecture for a while, since 2019, and I went back and looked at that lecture to see what the number was back then. And in 2019, it was 130 people dying a day from an opioid overdose. And now it's 220. So we haven't really made any progress. Things have actually gotten a lot worse in the intervening time period. Now, one of the big questions that still remains is what's driving all these opioid overdose related deaths? I mean, we know it's synthetic opioids, but it actually turns out that there's a lot of other new compounds, novel opioids that enter and exit the drug supply that have pretty significant impacts on opioid overdose risk, either decreasing or increasing the risk. The data that I'm showing here is from the Center for Forensic Science and Research and Education. This is the lab that we use for a lot of our studies. And they collect biological and drug specimens from places around the country. And what you see here, at least on the left, is sort of a composite of the novel opioids that they've found in their analysis in the drug supply. So some of these are going to be pretty familiar to you, like things like carfentanil or I don't think they have sufentanil in here, but you have all these fentanyl metabolites. And the other thing that's relatively new, which has been increasing in prevalence over the last couple of years, are these nitazines. So on the left, you see a bunch of these things that end in AZENE. So these nitazines are opioid-like compounds that some of which have more or less potency than fentanyl. On the right-hand side, you kind of see how the trends change over time. And the one that I would point out here is something like carfentanil, which is the light blue line, and you see sort of those spikes there. So carfentanil is significantly more potent than fentanyl. And what you can do, and what we tend to see actually in practice, is that as you get these spikes of some of these analogs in the drug supply, it'll correspond to increasing ED visits for non-fatal opioid overdose and also corresponds to increasing numbers of fatal overdoses. So there's not a lot of quality control in drug making, as you can imagine. You know, the labs are not really, you know, they're not state-of-the-art labs. So it's not clear if these things are getting in there. They're just byproducts of the process of making fentanyl, or if they're purposely in there. But every year we see new compounds, and these new compounds have pretty significant effects on the overdose epidemic. So that's the current state of affairs of opioid overdose deaths, which really, it gives us a window into the epidemic, but doesn't tell the whole story. For a little bit more context, you have to look at healthcare utilization. And that's what we're looking at here. On the left, you've got emergency department visits with a primary diagnosis of substance use disorder among adults. And what you can see is that there's been an increase in ED substance use related visits from about 75 per 10,000 between 2018 and 2019, and now about 104 per 10,000 between the year of 2020 and 2021. So those are the dark blue and the light blue bars there. And those increases are really for all age groups. So there's been this increase in substance use related visits. What about specifically for opioid use disorder related visits to emergency departments? Well, that's shown on the right-hand side. And this was another national study looking at ED visits for opioid use and breaking it down per 100,000 visits. And what you see here is that between 2025 to 2017, ED visits specifically for an opioid use disorder related complaint jumped from 89 per 100,000 to 250 per 100,000. So it's this steady increasing rise. So basically we see increasing everything, increasing overdoses, increasing ED visits, increasing, not increasing substance use related visits. And what's interesting here is that it's the same for every region. It doesn't matter if you're looking at urban, suburban, rural, we're seeing these increases all over the country. If we dial down that data a little bit more closely on those opioid related visits and look specifically at non-fatal opioid overdoses, you see the same data. I mean, it basically mirrors what I already showed. In 2018, there were about 70,000 ED visits for non-fatal opioid overdose. In 2022, there's 96,000. So a massive increase in the number of ED visits for non-fatal opioid overdose. Now, what actually happens to these patients after they leave the ED? For a long time, we actually didn't have great data about this. And you could postulate that if everybody got discharged from the emergency department after a non-fatal opioid overdose and did fine, then that might lessen the need for an ED-based intervention. But unfortunately, that's actually really far from the truth. And what really happens is that most of these patients do quite poorly. So this is a pictorial from a really good paper by Scott Weiner's group out of Boston that looked at patients who were treated and released from emergency departments in Massachusetts after a non-fatal opioid overdose between 2011 and 2015. And the patients were then matched with death records to capture their 1-year all-cause mortality. And the findings really were not good. So this is the graphic from the paper that shows deaths in the first 30 days following ED discharge. Overall in the cohort, the all-cause mortality at 12 months was 5.5%. So of patients who went to an ED in Massachusetts for a non-fatal opioid overdose, 5.5% of them were dead a year later. What this is showing here in the pictorial is that a huge portion of those patients, more than 20% of them, died in the first month. And a big portion of those died in the first 3 days. So this period, this post-ED discharge period, and I'm going to show you this, it's the same thing for hospitalized patients, is really a very high risk period for overdose-related mortality. This is a very similar paper by Mark LaRochelle, also from Alex Wally's group, basically using the same data set. And here they're all-cause mortality. So these are ED visits for opioid use disorder related complaints in Massachusetts. Their all-cause mortality a year was 4.7%. The thing that this paper adds is that if patients received a medication for opioid use disorder in the 12 months after their visit, then their all-cause mortality was halved. So it went from 4.7% to 2.2%. Now, there was some variability in the type of treatment the patients received and their all-cause mortality. So if they received long-acting naltrexone, those patients didn't do as well as the patients that received buprenorphine or methadone. But you can see that initiating treatment has a big difference. It makes a big difference in these patients' morbidity and mortality. And I like to use this slide to put things in perspective. Particularly in emergency medicine, some of the things that we get most concerned about and some of the things that we see most often are things like heart attacks and strokes. And for these two disease processes, we've gone to really like extensive lengths as a specialty to reduce the potential of a bad outcome after discharge to 2%. That's kind of like the magic number. And if you come to the emergency department with chest pain and my pretest probability for you having a major adverse cardiac event at 30 days is 2% or more, then more likely than not, you're not leaving the hospital. And we've developed all these accelerated systems to help work up these patients. Same thing for patients that come in with TIA and stroke. But compare that to what we've done for patients who present with like a non-fatal opioid overdose, as an example. This is a population that has as bad, if not worse, outcomes than patients who are presenting for these other complaints like MI or stroke. And yet we've done very little as a specialty, at least in emergency medicine, and I would also say for inpatient medicine, to actually address the outcomes, to reduce the bad outcomes in this patient population. But as I showed you before, we have the tools. I mean, if you get these people into treatment, they tend to do much better. So most of that data was for the ED patients. What happens to hospitalized patients? It's the same, basically. On the left, what you see is data from a national inpatient sample looking at the number of OUD-related hospitalizations between 1998 and 2016. And this is really showing similar increases in opioid use disorder hospitalizations. Over time, you get every year see an increase every single year. And this has continued up until the current time. The other thing that's interesting to point out is that patients who are hospitalized with opioid use disorder have a pretty significant increase in their in-hospital mortality in comparison to those who are matched but do not have an opioid use disorder, do not have an active opioid use disorder. Now, why this is not entirely clear, but it just is showing us that the patients, this is a really high risk patient population, both for outpatient morbidity and mortality after discharge, as well as for inpatient morbidity and mortality. Now, the prior slide showed hospital-related mortality for patients with opioid use disorder, but hidden in that data are all the patients that self-discharge. And I imagine this is not anything new to you working in the hospital, but a lot of patients with opioid use disorder wind up self-discharging themselves. And this is another paper by Alex Wally's group out of Boston that looked at self-directed discharge in patients with active infective endocarditis, obviously one of the major complications of injection drug use. And it's comparing patients who were admitted for infective endocarditis with opioid use disorder versus patients who were admitted for infective endocarditis for other things. And there's just a massive difference in the number of patients who self-discharge who have a history of injection drug use. So, we're saying they've got increased inpatient mortality, but they don't even stay in the hospital most of the time. And a big problem here, like, why should we even care about this? Well, we should care about it because patients who leave the hospital prior to treatment completion, secondary to early self-directed discharge, are more than twice as likely to die within the next 12 months in compared to those who don't leave or who don't have self-directed discharge. So keeping patients in the hospital is very important, in terms of preventing their long-term mortality as well as preventing long-term morbidity. Now, like we saw with post-ED discharge data, the data from post-hospital discharge in terms of what happens to these people, it's not any better. So this data is from the Oregon Medicaid system. And what it's showing here are the outcomes of patients that were hospitalized secondary to an opioid use disorder related diagnosis. So all these patients were admitted for some opioid related issue, either a complication from injection drug use or something else. And it's showing us kind of what happens to them 12 months after they're discharged from the hospital. So it's very similar to the ED-based data. At 12 months, 7.8% of the patients who were admitted for an opioid use disorder related complaint were dead, 7.8%. 4.5% of those patients, those deaths were attributed to a drug-related overdose, right? So really significant morbidity and mortality for this patient population after ED and inpatient hospital discharge. This paper didn't look at patients who got on treatment versus those that didn't, but I imagine it's likely to be the same as what we see for the emergency department. So it's all kind of bad news, I would say, but it doesn't have to be this way. There are very good treatment options, and there's a lot of things in our toolkit that have decades really of high quality evidence of efficacy behind them that definitively have been shown to reduce opioid related morbidity and mortality. So we're going to talk about what those different treatment options are and how you might employ those for the hospitalized patient. So the two treatment options that I'm going to specifically talk about are buprenorphine and methadone. I'm not going to spend a ton of time on methadone. We'll spend most of the time talking about buprenorphine. The one thing that I did want to mention before I talked about these treatment options is harm reduction. And harm reduction is really a way for patients who are not ready to initiate treatment. Harm reduction is a philosophy about reducing the negative outcomes of drug use. So things like preventing opioid overdose death or preventing skin and soft tissue infections. So some of the basic things here are the provision of naloxone, right? So if you have a patient who's in the ICU, who's there for a drug overdose, that patient should not leave the hospital without a Narcan rescue kit. I mean, that's really that's best practices. That's what needs to happen. Other forms of harm reduction, things like fentanyl and xylazine test strips, those are things that we do in the emergency department. So we're able to educate patients about testing their drugs to make sure that they don't have these other substances in them, or just to be more aware of what's in the drug supply. And then one of the most evidence-based forms of harm reduction is safe consumption centers. We are fortunate enough in New York to have two of them. It's the only two that currently exist in the United States. And there's actually a lot of evidence around safe consumption centers in terms of their efficacy, their effectiveness in reducing opioid overdose deaths, as well as complications from injection drug use. And there was a study, I took the slide out, but there was a study that was done in Edmonton where they actually set up a safe consumption center in the hospital for patients who were going to use. So, I mean, this again is not uncommon. I'm sure everybody's seen this. If you don't treat patients' pain or you don't treat their withdrawal symptoms in the hospital, one of two things is going to happen. They're either going to find a way to use in the hospital or they're going to have a self-directed discharge. So the Edmonton example was sort of a way to deal with both of those problems. Like they didn't want patients using in the bathroom, they wanted them supervised during their use. I don't see that ever happening in a hospital in the United States. It's just too politically challenging. But it is an option. These harm reduction approaches are very important and are a staple sort of the wraparound services that can be offered to patients with opioid use disorder. Okay, so that's sort of harm reduction. I just wanted to mention that before I talk about the specific treatment options. So the first treatment option for patients with opioid use disorder is really methadone. And methadone has kind of a long tortured history in the United States, and I won't really get into in any detail, but it's been around since the 1960s. It's a very highly effective treatment for opioid use disorder. It probably has the strongest base of evidence of all our current treatments. And it's also the most highly regulated and least accessible to most Americans. You're fortunate enough in New York that methadone is pretty easily accessible, but in most parts of the country, it's incredibly challenging to get into an outpatient treatment program, an OTP that provides methadone. So it's an option, and it's a perfectly good option for a place like New York, but it may be less of a good option if you're working in some place like Iowa or Idaho or something like that don't really have access to OTPs. In terms of treatment initiation for patients in the hospital with methadone, it's actually pretty simple. Typically, we'll start with around 30 to 40 milligrams of methadone and then escalate the dose every 3 to 5 days. Now, in New York, I've been told this a million times, and I've tried to find the regulations, and I can't actually find the regulations for dosing of methadone inpatient. But I've always been told working here at Sinai that the most we give for patients not in a methadone treatment program, so not in an OTP, is 40 milligrams a day. So that's kind of what we do. Patients get 40 milligrams of methadone a day. In other places, particularly in Canada, they just do dose escalation, which is what normally happens with methadone in the outpatient setting. They get started at 30 or 40, and then they escalate the dose every 3 to 5 days. Here in the hospital, if they're not in an OTP, you basically are limited to give 40. And if they're in an OTP, then you can just give them whatever their OTP dose is once you've confirmed it. You can also consider split dosing. This may be more effective for patients if they're also having significant pain. If you're starting a patient on methadone in the hospital, then one of the big challenges is like getting them into an opioid treatment program at discharge. So you have to make sure that you're able to give them a referral. And again, in New York, there's a lot of OTPs and there's a lot of access to methadone. So this typically is not a major problem, but in other parts of the country, it's a big issue. So methadone is a perfectly reasonable option. And actually our own data from the ED shows that we do about 4 times as many methadone starts as we do buprenorphine. But methadone itself has some significant problems, right? It's a full opioid agonist. So it can lead to pretty significant sedation in patients and respiratory depression because of it's a full agonist. It also is a pretty potent QT prolonger. So particularly for critically ill hospitalized patients who may already be on a number of other QT prolonging agents, methadone may not really be the best choice for you. And it's not great for patients with significant liver disease. So it's fine as an option. In New York, what we find is that most patients prefer methadone, and it's for a number of reasons. One, it's because of accessibility, it's what they're used to, and then there's a concern about precipitated withdrawal, which comes with the other treatment option, which is buprenorphine. So I'm going to actually spend the rest of the time talking specifically about buprenorphine. Okay, so buprenorphine. Buprenorphine is readily available in the hospital. It can be prescribed by any clinician in the outpatient setting. It doesn't require patients to go to a specific opioid treatment program. So it's less heavily regulated than methadone and much more easily accessible. When we're starting a patient on buprenorphine, there are a couple principles that we want to highlight. One is that this decision should be patient-centered. So it should be something that the patient wants. After a discussion about treatment initiation, is buprenorphine the right option for you, or is methadone the right option for you? When we think about buprenorphine or methadone, we tend to think about long-term treatment. This is not going to be an issue for hospitalized patients, but the idea is not to detox patients. We don't detox patients off opioids. I know people will talk about this all the time, and patients sometimes want to be detoxed off opioids. And there are places that do this. They'll do like a short methadone or buprenorphine taper, but it's terrible because when you detox somebody off opioids, you basically have now eliminated their underlying opioid tolerance, and their likelihood of relapse is like 90% in the acute period. And you now have taken away their tolerance, they go out and use, and they have either a non-fatal or a fatal opioid overdose. So we don't want to detox patients. When we start a patient on treatment, whether it's methadone or buprenorphine, the idea is to keep them on long term. Now, do they have to be on it forever? I mean, that's not really a discussion you necessarily need to have in the hospital, but no, they don't have to be on it forever. Patients who have been stable on treatment for long, long periods of time and really want to come off, then we can actually try and taper them off. You can think about buprenorphine as a treatment option. We also like to think about it as a method of harm reduction, because patients who are therapeutic on buprenorphine are much less likely to die from an opioid overdose. Medication in this case is the treatment. So you'll hear people refer to refer to medication-assisted treatment. This is a term that we used to use quite a lot, MAT. We've sort of tried to move away from that to medications for opioid use disorder, and that's because the medication really is the treatment. And there's been a lot of data that shows that many patients don't necessarily need the counseling that comes along with the treatment. For some people, it's beneficial, but it's not required. Patients tend to do well just with the medication itself. So it's a medication first approach. We'd like to start patients on this same day. That's sort of like a low barrier threshold initiation. This is what we do in the emergency department setting. And then it's important to remember that it's part of this biopsychosocial model of care so that, it's not, again, the medication is a major component, but there's a lot of other things that contribute to drug use that need to be assessed, and things like housing and housing security, food insecurity. So it's part of this model of trying to deal with a lot of things that lead to drug use. So there's a lot of formulations for buprenorphine, and I'm going to mention a bunch of these as we talk about treatment initiation options. At Sinai, we have all of them. So there is buprenorphine that comes as mono formulation. So this is Subutex, and Subutex is available at all sites, but it's used most commonly at MSH and MSQ. We also have Suboxone. Suboxone is buprenorphine films that are co-formulated with naloxone. And then we have long-acting injectable buprenorphine. And I'll talk about each of these. I'll talk about long-acting injectable and sublingual separately. The co-formulation with naloxone, just in case people don't know this, the naloxone doesn't have any biologic activity when it's taken the way that it's supposed to be taken. So when patients take Suboxone sublingually, there's very, very little naloxone absorption. The only reason the naloxone is in Suboxone is to prevent misuse. So what you can do is you can kind of crush up the tabs, or you can melt the films and then inject them. And if you do that, then you're going to get the full dose of naloxone, and that's going to precipitate withdrawal. So that's the only reason that it's there. It doesn't have any other purpose. So the properties of each of these delivery mechanisms really affects how we do the treatment initiation. This is a diagram that's showing the pharmacokinetic curves of patients who've been given sublingual buprenorphine. So something like, this is Suboxone particularly. And what you see here is that there's this pretty precipitous rise in buprenorphine plasma concentrations. And actually peak plasma concentrations are reached after about 20 to 30 minutes, after which you see a pretty sharp decline and then this long tail. The little dots at the bottom, those little triangles, that's the naloxone absorption. So it's basically nothing. The reason why this is important, knowing the pharmacokinetic curves is important, is because patients who are given sublingual buprenorphine, if they have full agonist on board, so if they just used heroin or fentanyl, and you give them this whopping dose of sublingual, they're going to get really high concentrations of buprenorphine really quickly, and that could potentially lead to precipitated withdrawal. And why is that? So why would you get precipitated withdrawal from this agent? I try to explain that here. So buprenorphine, for those of you who don't know much about the drug, it's a partial opioid agonist with a very, very high binding affinity for the opioid mu receptor. So what happens is that if you have a patient that's on full agonist, so just took fentanyl or has methadone in their system, those full agonists are bound to the mu receptor. And the receptor is completely activated, fully activated. If you give that patient buprenorphine, what's going to happen is the buprenorphine is going to preferentially bind the mu receptor because it has a much higher binding affinity. And it is going to kick off all those full agonists. It still activates the receptor. So it's not that buprenorphine doesn't activate the receptor, but it doesn't activate the receptor to the extent that the full agonists do. So in reality, what the patient experiences, the patient who's on full agonist, who gets buprenorphine, what they experience is like what would happen if they got naloxone, because you've kicked off all the full agonists and given them this partial agonist, and they experience that as precipitated withdrawal. So that's buprenorphine precipitated withdrawal. That's really the most feared consequence of the treatment initiation, most feared among patients, and I think also most feared among clinicians. We'll talk about how to address it at the end, but this is the one property about buprenorphine that can be problematic, at least for the treatment initiation process. The other property for buprenorphine, and one of the reasons why we prefer this drug sometimes over methadone, is that it has this ceiling effect. So you see that middle line where there's that long plateau. What that basically is telling us is that, after a certain threshold, which is about 32 to 40 milligrams of buprenorphine, you don't get any more increased effect on respiratory depression or sedation. Those are the two main things where we get this plateau. So you can give a patient 40 milligrams of buprenorphine or 140 milligrams of buprenorphine, and really there's not going to be much of a difference. So as a drug, it's actually very difficult in an opioid dependent patient. It's very difficult to overdose on buprenorphine. Now, if you're taking buprenorphine with benzodiazepines or alcohol, that's a different story. But buprenorphine itself has this ceiling effect, which is really nice. And the other thing that's really nice about it is that because of the high binding affinity, if the patient's therapeutic on buprenorphine and they go out and they inject a whole bunch of fentanyl, they're relatively protected from overdose because the fentanyl is not going to be able to bind the opioid receptor and activate it, because those receptor areas are occupied by buprenorphine. Okay, so I'm just gonna, running out of time. So how do we actually do treatment initiation? There's a bunch of different treatment strategies. There's standard and high dose. So we've been doing treatment initiation for a long time. This is tip 63. This is the published guidelines from SAMHSA. And this is kind of the way that we did things pre-fentanyl. We waited for the patient to go into withdrawal. So maybe we did like a washout, said, hey, don't use drugs for 12 to 14 hours and then come back. And we'll start you with 2 milligrams of buprenorphine, wait a couple hours, give you another 2 to 4 milligrams with the max day 1 dose of 8 milligrams and the max day 2 dose of 16 milligrams. Initially, this was done as observed initiations. Most times nowadays, this is done as outpatient unobserved initiations, but this was all pre-fentanyl. So we tend not, this protocol tends to be a little bit too low and a little bit too slow for what we're seeing now in the fentanyl age. This is a standard sort of widely used ED-based protocol for treatment initiation. So here again, if patients are not in adequate withdrawal, then, and when I say adequate withdrawal, that's typically a clinical opioid withdrawal scale of 8 or less. Those patients just go home with a prescription and they do a home initiation, just like I showed you in the prior slide. If they've got withdrawal, so a clinical opioid withdrawal scale of 8 or greater, those patients can be initiated in the ED or in the inpatient setting. And here we tend to go with a little bit higher doses. So we tend to start with 4 to 8 milligrams. We don't wait as long. We don't wait 2 hours. We wait about half an hour and give another 48 milligrams with a day 1 max dose of like 12 to 16 milligrams. So this is a protocol that's used pretty commonly across the United States. This is probably the most commonly used high dose protocol. This is out of California Bridge, which is a program that does ED implemented buprenorphine in California, and they are in about 240 emergency departments. So this is what I would call more of high dose initiation. So here they're really starting with 16 milligrams, 8 to 16 milligrams, and then giving another 8 to 16 milligrams for a day 1 total of 32. So this is what we'll call macro dosing or high dosing. I will tell you there's not a lot of data around these things. This group, the California Bridge group, did publish a retrospective chart review of high dose initiations showing that they were safe. So, there was no impact. These are all patients that got more than 16 milligrams of bup during their ED stay, and there was no impact on their respiratory rate or their oxygen saturation. And the only serious adverse events that they had were like hospitalizations, but they weren't due to the buprenorphine that was given. So at least retrospectively, it seems like it's safe. This is what we're looking at prospectively in my UG3, which is basically 2 studies, this complicated diagram, which is basically a escalating dose cohort study where we start with 12 milligrams and then escalate the dose in each of the cohorts to get up to about 32 milligrams to make sure prospectively that it's safe. And that's going to be followed by this randomized controlled trial where we randomize patients to standard versus high dose buprenorphine initiation. And the outcomes here that we're looking at are things like engagement and treatment at 7 days. So this study is ongoing. I don't have any results for it yet. The most common strategy that you're going to probably run across in the hospitalized patients are these low dose, they're low dose, microdose, cross tapers. So this is what's commonly used for hospitalized inpatients. And again, there's a lot of different ways to do this. There actually is a microdosing protocol in Epic in our health system. So it's already built into the system, and it actually builds upon some of the low dose initiation protocols that I'll talk about. These are very helpful for patients that are getting full agonist. So patients that are in the ICU or patients that are on the floor who are getting full agonist for pain, these protocols are very, very helpful. So I'm just going to run through a couple examples. This is a protocol that uses a buccal form of buprenorphine to deliver low plasma concentrations for a few days and then transfers over to sublingual. So this protocol uses Belbuca, which we have on formulary at Sinai. I will tell you that Belbuca is not FDA approved for the treatment for opioid use disorder. So it's being used off label. It's fine to do that in the hospital, but this is not something that we can actually do as an outpatient. So for these protocols, like I said, they're cross tapers. So the patients get escalating doses of Belbuca, they stay on their full agonist, and then they transfer over to sublingual. And then after a period of 7 days, you drop the agonist and you just give them full dose bup. This is another protocol, another 7-day protocol that just uses sublingual strips. So again, you just give them like escalating micro doses of the strips each day up to day 7, continue the full agonist, and then at day 7, you stop. In Epic, we have 2 protocols that we built for microdosing. One is a 6-day protocol and one is a 3-day protocol, but they're very similar to these. Patients who are on methadone, so maybe the patient got methadone in the ED, but now wants to transfer over to buprenorphine, not a problem. This is a rapid cross taper from methadone onto bup. So a patient gets standard, same dose of methadone each day with escalating doses of small amounts of buprenorphine. And these slides will all be available so you can sort of see what it looks like. But these are very successful type transitions. Now, the patients may still have some withdrawal symptoms, but they're not typically going to go into full-blown precipitated withdrawal. If you want faster than that, this is a 48-hour protocol, which basically starts with like Q3-hour dosing of medication for 2 days. If you can get the nurses to do this, that's amazing. But if you want to do it quick, then this is one of the protocols that you can use. And then this group in Canada has sort of taken this to the extreme where, okay, so it's really hard to give Q3 medication doses. So what we'll do is we'll just do transdermal buprenorphine. So what they do here is they slap on 6 transdermal patches at time 0, another 6 transdermal buprenorphine patches at 12 hours. And then after 24 hours, they give them sublingual and pull all the patches off. There's a couple case studies for this. This is not something I advocate, but I sort of wanted to show you kind of what the range of possibilities are for inpatient treatment initiation. Now, the question is kind of like, how do you choose? Like, which one of these things should I choose? Should I choose high dose? Should I choose standard dose? Should I choose low dose? And I wish there was really a simple answer for this about, what's the best one. But unfortunately, it kind of depends on the circumstances. So ASAM, which is the American Society of Addiction Medicine, published this really nice guideline recently about how to choose the initiation protocol under which circumstances. But the general rule of thumb is that if the patients are in withdrawal, then standard or high dose is probably what you should go with. And nowadays, most people are just going with high dose, right? So they're already in withdrawal. You're pretty good just to, deal with their withdrawal quickly, give them the buprenorphine they need, and that's it. If the patients are not in withdrawal or if they're taking full agonists, those are the patients where you really need to do these micro initiations or these low dose cross tapers. So that's kind of the rule of thumb. And that's sort of why a lot of inpatients are getting low dose cross tapers because they're on full agonist already. This is a relatively evidence-free zone. So I'm telling you all this, but I can't really show you the data because there's not great high quality data around any of this stuff. Okay, the last thing that I'm going to talk about, this is probably the most exciting thing that's sort of coming down the pipe for treatment initiation, both inpatient and outpatient, are these long-acting injectables. And this is what we're actually studying right now in this really large randomized controlled trial. So I'm part of this NIDA-funded study called ED Innovation, which is a type 1 hybrid implementation effectiveness study. And it's basically a randomized controlled trial that compares long-acting injectable buprenorphine, and we're using a 1-week formulation called CAM 2038. This actually just got approved by the FDA in October, so it goes under the market name of Brixadi. And we're comparing that to standard sublingual initiation in 2,000 emergency department patients across the country and looking at their engagement and treatment at 7 days. So we've got these 30 sites. And, over time, a lot of them have dropped out. So we're down to about 9. But we have a pretty good geographic distribution of the number, geographic distribution of the population in which we're doing this. And as of this week, we're at 1,900 patients. So we only have 100 patients to go. So this data should be out relatively soon. The nice thing about these long-acting injectables is that, here you see that big spike of buprenorphine from the sublingual. The dark black line is the long-acting injectable. So the nice thing here is that it has this sort of slow increase in plasma concentration. And what this allows us to do is give buprenorphine to patients who are in less degrees of withdrawal. So we can start medication for patients who have COWS scores of 4, rather than waiting for them to go into more severe withdrawal with COWS scores of 8 or 12. So it gives this sort of, think about it kind of as like an injectable microdose. And it's really been working quite nicely. Again, we won't have the full data until next year. I'm going to skip this just so there's times for questions. It just shows that our experience with the long-acting injectable, basically, we have very, very low rates of precipitated withdrawal for patients that have COWS scores of 4 or greater. Feasibility, can we actually do this in the inpatient setting? Yes. This is not a great study out of one of these this is not a great study, but it is like a cohort study from an ICU reporting on patients who got buprenorphine, and basically using their low dose protocol, patients did fine. Low risk of precipitated withdrawal, and it reduced their opioid agonist requirements. So that's it. I'm actually going to skip over the precipitated withdrawal things just to leave a little bit of time for questions. I'd like to end with a slide. We can change the way we think about addiction. We can change the way we talk about addiction. And we can change the way we treat addiction. So thank you. Hopefully that was informative.
Ethan, that was great. Thank you so much for giving